We covered all the basic things this week, including needle handling, needle holder handling, suture selection, thumb, ring finger, middle finger on the angle, index finger on the shank, the palmed grip or the palm grip. We've covered things for speed, so palming your forceps. When you finish tying your knot, putting all your instruments into one hand and cutting, keeping your scissor, as always, palmed into your palm here, but not letting the tips go into your finger, just off the edge. Today, we're going to cover, like I said, where I think people make mistakes. Now, the first is actually to do with the interrupted stitch. If you have any questions, you're always welcome to ask, or you can pop it in the chat and I'll answer. The first thing that I notice often in theatre is when people are doing the interrupted stitch, deciding whether to tie perpendicular to the wound or parallel to the wound. I think this needs to be more intentional. So if you're just doing a standard suture, you need to tie perpendicular to the wound. You need to make sure you're tying between the long and the short, and the long and the short alternate. But there are circumstances where you may want to tie the interrupted suture parallel to the wound. And those circumstances are specifically for where you want to get good wound eversion. And in my experience, when you've got slightly thinner skin for the dorsum of the hand, or maybe the face, forehead. But to do that, you have to do two things. Take a reasonably sized bite and a reasonably sized bite. It might not work on the skin pad, but it will work in real life, I can promise you. You tie, and immediately you tie it transversely rather than perpendicular. So you go parallel straight away. And what you will see when you do that is that the wound will evert, but you have to keep tying parallel to the wound. Like I said, on thick skin, such as this skin pad, or on glabrous skin of the hand, doesn't really work. But on the back of the hand, or on the face, or maybe even on the lower leg, if you take a decent sized bite, and then, so a decent sized bite in terms of distance from the wound edge, and tie it parallel, it will evert the edge like a mattress. So it's another simple way of doing that. The next technique, I think people need to make sure that they do really, really well, is the buried subcuticular. So everyone seems to do it. I wouldn't say everyone does it well, but I think there are a few things you can do to make sure you do it well. I'm just looking for a dyed suture to do this with so that you can see it. But in reality, if you're doing skin, use an undyed suture. And if the skin is thin, so in pediatrics or in the elderly, you may want to use a braided suture because the braids of the suture will grip the dermis better. There's two ways to start it. My preference of starting is just to do deep to superficial on one side and tie, but some people would do deep superficial on one side, superficial deep on the other side, like a deep dermal. Tie it, only cut the short, and then run it. Regardless of what you do, anchor your knot at the beginning, take a good bite, and make sure it's buried. This is not the task. Palm the forceps, pull the suture with one hand, 1, 2. Tie or knot, as we discussed yesterday, just use your finger to tie. You don't have to move your whole body around the patient. Just use your finger, finger tight. Palm the instrument, cut, and go again, and then you're ready to continue. But the first bite, in my experience, needs to be backwards. It needs to be backwards because otherwise you'll have a gap in the apex. And I think this is the first. This is the key to a good subcuticular that you do not need to correct at the end. And you can see that it's already closed, and then you just continue running the suture. And it's a superficial bite in the dermis, just beneath the epidermis. You don't need to stitch fat. It's literally as superficial as possible without seeing it come through the skin. I'll do a couple more zoomed in, and then I'll zoom out so you can see how my hands move. You want to make sure you get a good bite. And by getting a good bite, I mean the excursion through the skin. So with this, you can see the suture goes this way and then this way. It's not a straight line. It completely curves around and goes. So if you go in, opposite where you came out, push the skin back to make the needle exit, grab it with the forceps, pull it, mount it straight away, and then pull. This means that I'm ready to carry on suturing, and there's no delay in terms of speed. Push it back to make it exit. You want to make sure you're at the same depth throughout. Grab it with the forceps, not at the tip, but along the body. Mount it straight away, pull, and you can see that it's approximating pretty nicely, and there's not really any gap at the beginning either, which is all I want. As you go, I don't tend to get longer with my bites unless it's a really long needle or a really long wound. Otherwise, I kind of keep the bites the same distance. And I'm alternating between the palm grip and the, I'll put the scissor down, alternating between the palm grip and the traditional grip. And that's just so that I can get the excursion into the tissues so that it grips and will close the wound nicely. Don't need to put any deeper tissues in here because the edges are already approximated. And then as I get to the apex, I start taking two smaller bites. This one will come right to the apex. You don't want to be too superficial, especially if you're using a dyed suture, which I've already explained is not ideal, but for teaching it's great. And then take another small bite, but I just want to go a bit deeper so that my knot is buried. If I can find my knot. Yeah. And then it's time to do an Aberdeen knot. I haven't got much suture, but it will do. You make a loop, pull the suture down, pull the under loop, and then you carry on. It's a monofilament, so ideally between 4 and 6 knots. And pull. And then put the needle into the loop and come through. And then you bury it. And pull. And I would say that is how your subcuticular should look at all times. And I think the key to that is the first bite and the last bites are quite small. The first bite goes back on itself, and then you continue in the apex. Make sure you get a good excursion opposite like a ladder or snakes, and then small bite, and Aberdeen knot. Secure your needle, another area where people make mistakes. If you're going to use the needle again, just put the needle towards the face of the needle towards the body of the needle holder. If you're not going to use it again, you can always put it in the jaws, and then it's really secure. Make sure it doesn't come poking out the back, otherwise it gives someone a Sharps injury. That's the interrupted suture in terms of whether to lay it perpendicular or parallel. And then that's the subcuticular suture, avoiding any missed gaps at the beginning, avoiding gaps at the end with an Aberdeen knot at the end. The next technique that I think people struggle with is the deep dermal. I think there are some real key points to really focus on here. If you think you're really going to struggle with closing the wound, the first thing I would suggest is that you use a braided suture. The second thing would be that you use a reasonably sized needle. Now, I'm going to use one of these monofilament sutures that I have available, and we'll see if it works. Because the skin pad has seen a good amount of life. So, the description of the deep dermal is to go from deep to superficial, and then superficial to deep. You always start on the side closest to you because economically it's easier. You do not need to stitch fat or muscle. You just want the thin white layer of tissue underneath the epidermis. To get a really good bite, you cannot really go vertically because that will only get you at 1 or 2 mils of tissue. So the best thing to do is go obliquely, not transverse, oblique. So stabilize the skin, go in deep to superficial. If it was to come out, it would come out here, but that's not the right place. So I'm then gonna rotate my wrist and push the skin back. I'm gonna follow the needle and see where it comes out. Push it, grab it along the body with the forceps, like this. Mount it straight away and pull. And then rotate the instrument. You follow the same trajectory as you did to start, but you go from superficial to deep. Grab the needle with the forceps, put it through, and you're there. Now I've placed this stitch where I can see a rip in the skin pad, so it may not hold, but let's see. 2 revolutions on the needle holder, which is the surgeon's knot. This bit's key. You tie parallel to the wound for a deep dermal, not perpendicular. That will pull the wound apart. You don't want to do that. You want to put it together. Look at that. If it's gonna gap or you're scared it's gonna gap, pull it to one side, like when we do the locking knot. That pulled my suture up. Wonderful. So we're gonna do that again with the longer suture. So we're going from superficial to deep, obliquely. So we're going from deep to superficial on this side, and then superficial to deep. Rotate your wrist. The needle's a bit short on this one, so I'm doing it in 2. And then pull. It's really about getting that good excursion in the tissues, and then that way it doesn't. So if you see my wounds come out unopened, so I could undo it, but I'm going to rip the skin doing that. So I'm going to do a slip knot, so the short end's going to come back to where it came from. And then just pull the short end till it closes. Now it's closed, I'm going to pull the long end, and that's that. And then both sutures go up. I need to cut flush on the skin, so you go in, open, slide down, angle it, cut above the knot. I'll do another one down here. And it really is about precision in placement. So it's about the precision of placement. So this is just the deep dermal, from deep to superficial. Rotate the instrument so that I can go from superficial to deep. Be precise. in terms of where you're locating it. See that it's in the depth of the tissues. Grab it with your forceps if you can, and then pull it through. 2 revolutions, which is the surgeon's knot. Tie it parallel to the wound for the deep dermal, not perpendicular. Perpendicular will open the wound. We want to go parallel, like so. My finger ripped out again, so we're going to do it again. That's fine. I can see that it's under some tension, so we're going to do that technique that we talked about earlier in the week, where we put a temporary suture in to take off the tension. It's just a big bite with a stitch I'm going to cut out towards the end. Index finger goes under. Short suture goes on top and forms the cross. Press on the cross to keep the tension there and the wound closed. Go under the loop, pull the short suture through. My tension is still where my finger is. Continue to pull the short suture. The tension is now up here. When I'm happy the wound is still closed, pull the long suture, and then your knot is locked. And now I can put in my deep dermal without tension here. That's a really good technique for taking your tension off your wound, putting your deep dermals in either side of it, and then you can cut it out after. And again, if you've got a wound that's under tension, you're putting in deep dermals, you can do that technique and also use a braided suture because it has more grip. Of course, I'm using a monofilament suture because that's what I have here today to use. I'm parallel to the wound because I'm not under any tension, just using my fingers to tighten it. I'm not moving my whole body. Comes together even better. We were talking about this yesterday. If in theory your deep dermals are perfectly approximated and you're happy with the closure, in theory you can just put some glue and some steri-strips on it. That's not unreasonable. But if it's over a mobile area or a joint or a place where there's movement of the underlying muscles, such as on the face with talking, you may want to put the superficial layer as well, so that the epidermis is clearly staying opposed to the opposite epidermis. Again, tie in parallel. I think being economical with your suture is also important because the time it takes for your scrub nurse to get you another suture, you can be asking for that suture now rather than waiting after. They often don't like to take excess sutures out. You ask for 3, they'll take out only 1. So I tend to use as much of the suture as possible. And as I'm coming to my last stitch, I ask for another. So that is the deep dermal and the technique to take off tension off your wound temporarily. So your deep dermals don't have to do so much when you're putting them in. The next technique we're going to do that I think is an overlooked technique is the continuous suture. It's overlooked because I don't think people do it enough, and I think when they do it, they take too long to do it. So let's do that next. I'm going to do it on this segment of wound here. We're going to use silk. That's just because it's easily visible during this tutorial. If you ever have to take suture packets out for your sutures out for yourself, this is what you need to do. You see the needle, you see the swagen where the suture material attacks, and the point is over here. You want to be at the very tip of the needle holder, not down here. Push it against the packet, grab it, and then pull the packet away. Don't pull the needle out of the way. So let's pretend we're doing a wound in a 15-year-old in the emergency department. Just a quick, debrided the wound, cleaned it, just a quick continuous suture. The reason I'm using this environment is purely because in the environment of A&E, you don't have a big sterile field. You have a few pieces of equipment, silk being usually one of them, and you don't want to be putting all your instruments down because you might not see them again, they might drop on the floor, that kind of thing. Because the procedure room is formally blocked and in use, so you're just doing it at the bedside. So, first thing is palm your scissors because you're going to need them. Put your suture in. You've got lots of other things to do. It just needs to be a quick stitch. Palm the forceps. Pull the suture with one hand and just tie your knot. So what we're not doing is this, like we're doing somersaults with the suture. Yeah, you're going close to the wound, pushing the suture forward and just wrapping it around the tip. Not down here. Your arm isn't moving like this. You're just wrapping around the tip. 1, 2, and tie. With your finger, pushing the tension and tie. These are small things, but it's the difference between whether someone looks at you and thinks you're an amateur or you're a pro. One suture goes up, one goes down. The one that's up is the one you cut. This is exactly what I would do. Keep my forceps in my hand, my sutures in between my other fingers. Cut this one short for myself. And then I start sliding my finger down, put the tension on this side, and I pull till the needle makes my fingers. In the same grip, I just show myself where I want to mount the needle and mount it. I don't then have to remount it. There's no adjustment. Everything is within my field. And I just start suturing. So the key now for speed is to grab it with the forceps, not at the point, but along the body. Mount it straight away. Pull, rather than the needle coming towards your face, pull the suture with the forceps, and then carry on suturing. There's another nuance to that. Push it with the forceps, pull it straight away, go like this. Obviously, beware of any things that you might get caught on. Pull. As you're pulling the suture with the forceps, bring your needle near to where you want to operate, and then you're ready to just carry on suturing. They aren't big things that will save you time. It's not about speed, it's just about reducing maneuvers that waste time and anticipating your next steps. So as you're doing this, or ideally, the order in which you do all of this, you see the patient, you decide a plan. If you have to do a consent form, you do a consent form. Put the local in. Whilst the local is working, go and get all your equipment and set up your sterile field. That way you don't start before the pain has been removed. Get lots of drapes just for your area and a vomit bowl because often, patient will start to feel sick in the middle of the procedure. If you can get a chair, that's great. If not, then do it standing. Make sure you've got lots of good light. And then also get your dressings and open them to start with and get a spare suture. If you're in theatre, at this stage, this is the wound closure. You need to start thinking about what dressings you want. So at this stage, if I was doing this, I'd ask the scrub nurse for steri strips and, a Cosmopore or an oxide dressing or whatever you're going to use, or just the micropore tape. But it's the anticipation of the next steps rather than waiting till the very, very end for asking for these things. At this stage, you want to double check that they're sending for the next patient. You don't wait till you finish everything before you do it. This stuff needs to be a smooth transition. And so the key to all of this is that I'm not having to remount it after I've mounted it once. You push through. If it's too short, you push through again. Grab it with the forceps, not at the point, but along the body between the teeth, or you can go sideways on if your forceps are fine enough. Mount it straight away and pull. If you have any questions, obviously pop them into the chat. And pull. My suture keeps getting caught on my skin pad because I've for once got a very, very long suture. So at this stage, I can see I'm locked. Just gonna unlock it. And I just try and do things so that I don't have to keep grabbing my needle too many times. I don't think that took too long. I think it's quite quick, and I think it's quick because of just the continuous grabbing. And then treat your short end like a single, wrap twice. So we mentioned a bit about dressings. I'm just going to dwell on that a little bit more. In terms of selecting your dressings, I think you keep it simple. The simplest dressing that will allow the patient to have a shower, live their day-to-day, not get in their way. So the thing that I think people make the biggest mistake with is iodine-based dressings and antibacterial dressings. The best solution to infection is to wash wounds. Iodine does one very good thing very, very well. It dries out very quickly and it's only active for about 24 hours anyway. If you put an iodine-based dressing on a patient, let them change it daily, and that means that they can have a shower with the dressing off and then reapply another dressing the next day. If you're not going to change the dressing for more than 48 hours, don't use an iodine dressing because it'll get stuck. And then most recently, the thing that I think I found, but maybe people don't consider, is iodine in children is never a good choice because it dries out and gets stuck. Changing the dressing whilst they're awake is an extra pain. They're already upset because of changing the dressing, but they're extra uncomfortable because it's dried and stuck on the wound. The easiest way is to get them to have a shower to help it lift off, but it's still uncomfortable. So you choose dressings that are simple, that don't interfere with their day-to-day. If you're going to do something for antibacterial things, have a suitable arrangement such that they can be changed within its time frame. And if it's iodine-based, don't use it in children and change it within 24 hours. So we've covered interrupted suture, laying it perpendicular. If you're going to do it lay parallel, it's for thin skin that you want to evert, like the back of the hand, the face, the eyelid. Take a decent sized bite away from the wound. We've covered the subcuticular suture, my tip being start at the beginning. My personal preference is just to put one suture on one side, tie a knot, but the key is to run it back on itself in the apex so you don't have a gap here, and then continue from this side, going in opposite where you come out. Go in as superficial as possible without coming through the epidermis. Use an undyed suture. And if the patient has thin skin, so usually the elderly or babies, consider using Vicryl because it has better grip. In children, just use dissolvable stitches anyway. With the deep dermal, we talked about the direction of the travel. So it's from deep to superficial. You always start on the side closest to you, and then you go from superficial to deep. Two key components of that would be you get more tissue if you go obliquely from deep to superficial and obliquely from superficial to deep, because oftentimes people will go deep to superficial and take the fat and fascia underneath, which is not necessary. It's just for dermal closure. But you go obliquely, so you get the tissue all the way from here to here, rather than just from here to here. Far more tissue in between, more grip. And the same thing on this side. But you tie the deep dermal parallel to the wound, not perpendicular. If you tie it this way, it will open. Like that way, it will close. If you've got a wound under tension, we'll just do that trick one more time. So I'm going for the biggest part. I put a temporary stitch in the middle. I'm just going to take a big bite. You're doing 2 bites. Grab it with the forceps straight away, mount it straight away, and continue. You can lock the knot, you can slip the knot, but I find for big gaping wounds, the thing you just want to do is 1, 2, hold it, and then with your hand overhand, pick your index finger, go under the long suture. I'm just going to bring this way so you can see. So you're here, finger goes under, suture goes over, you make a cross, push your thumb over that cross, and then you see this suture here, that belongs to the long suture. You go under it and pull the short suture through it, but you're still maintaining the tension on that cross. The wound is still closed, and I'm holding it closed by holding the cross here. That would typically be down there. Then you pull the short suture. You can let go, put it taut really tight, and let go of the long. It should make no difference. So that means you don't have to drop it, but you can now pull the long suture so the wound closes. And you can do that for wounds that are gaping and you're planning on just closing like this temporarily anyway, or you can do it so that it takes off the tension whilst you're putting your deep dermals. And then we've talked about the continuous suture. The key to just being speed is that you go through, grab it with the forceps, mount it exactly where you want it the first time, and then you just continue. And we talked a bit about anticipating your dressings, your next case, and what dressings you're going to use. Iodine dries out, so consider a change of dressing in 24 hours and a shower if it's to do with infection. One of the other things that I think is important to talk about is how to cut. So I'm actually going to use an old skin pad to demonstrate this. And I think the cutting is a really important part of this. If I just demonstrate this on this old skin pad, give it a wipe. So often we start with a lesion. It starts like this. And then they're never that straight, are they? They're normally a bit asymmetrical. Then you need to mark it up. So the thing with the marking up of these things is there's a tendency for people to get really heavy-handed with the ink and start drawing these lines. I think approach with suspicion first and kind of just dot it. So if you need to define often you have these lesions that have some erythema around it. So you want to define the abnormal bit. So let's say there's some erythema like this. So the way I would define it is just by doing dots around the edges of that erythema. And then with all these things, you always have to add a margin for the excision, right? So then I discreetly get my little ruler, measure it, and I'll do small lines, not heavy-handed in ink, follow the curvature of the original lesion. And then it's just a bit neater. And if I need to change something, it's a bit more discreet. The key to remember all these things is, can you close it or can you not? If you can close it primarily, it's in a straight line. Therefore, it is into an ellipse. The ellipse is the 3-to-1 ratio so the length of the length of your ellipse needs to be 3 times the width of the lesion. So we're not going to change the width of this, but the length needs to be something like this. So where does this not apply? This will not apply on the face. On the face, you do not need to excise an ellipse. Excise it as it is and close it. If you think it can close, and then close it as it is. You find the way the muscles are, the way the skin aligns in the different direction of the muscles, and the way they pull the skin. You often will find that you get away with a much smaller ellipse than you think. So all you need to do is take it off, close it, and if you can't make it so that there's no dog ear or standing cone, you just excise what is there at the end when you've closed it, rather than taking a scar all the way down here when you could have just had a scar that ended something like that. The other place this doesn't apply is if you're not going to close it primarily. If you're going to put a skin graft in or purse string it or leave it open, don't take it as an ellipse. This is all you need for your excision. So let us do an excision. And this is the second thing that I think people struggle with. So often the nurses will mount it for you, but that angle has to go on there. That angle has to go on the groove. When you are cutting, don't cut towards your fingers. Cut perpendicular to your fingers. And as you cut, you put more tension. So what you want to do to start with is use the belly of the blade and score everything. Where do you start is the question that you need to ask yourself. So let's say the patient is, for the sake of saying, for the sake of um, understanding the position. So you're all sitting in front of a computer. Computer is here, you're here. The patient is, this is their back. So they're lying on their side, face is away from you on this side, and this is their back. The lesion is in this orientation. The right arm is here, left arm is down here, head is up here, legs are down here. You start your incision on the inferior surface of the cutting because blood will flow. When you cut here, blood will flow and it will not get in your way of when you cut up here. If you cut up here first, blood will drip down and get in the way for when you cut here. So whenever you have a choice of where to cut, start on the inferior surface first, so blood flows down and doesn't get in the way of the top, and then you can do the top. So we've scored our surface, and if you have done a few skin excisions, you know the depth you need to get to. On the back, I know I need to press pretty hard and probably with a 10 blade to get down to some subcutaneous fat. If that's the depth I'm going for, usually you're either going to fat or to fascia for any excision, depends on the problem. So once you've scored it, you have a look and you see, do you see depth you want? If you don't, then you go again. The next thing you need to look at is the depth uniform? So here, I can see the yellow fat. Here, I cannot. So I'm just going to extend it a bit deeper till I see it. And then you lift one edge where you can put, so always release the apices as well. You lift up one edge, you pull it quite tight, and then you start cutting. And the key is this hand. It's pulling the tension and it's almost ripping the skin off of the surface you want to detach it from. And all you have to do is sweep it off at the depth you want. But if you haven't released this to the depth you need, then you have to do that as you go. But this is the key, and you keep pulling harder and more and you sweep from top to bottom. Top to bottom. You need to get to the right depth there. You sweep from top to bottom, keeping the tension in this hand. And it's a really significant pull, and the counter traction with your little finger here. You sweep from top to bottom to keep the right depth. Now, the challenge for what I'm doing is that I've got a skin pad on the other side with pre-cut holes. So we can see how good I can do this if I don't make or reach one of those holes. You just want an even depth. And the key, even when taking a full thickness skin graft, the key is the traction, counter traction. As you can see, I haven't released this completely. I'm just going to go here. And then I pull, and I pull, and I pull. And as you get to the apices, you just have to make sure you don't go through. Just release, release, release. And then you're out. And then what you're aiming for is to have a uniform base on your lesion, all of the same depth, and all of an even depth here, which I've mostly achieved. Small little hole down there, but that's okay. I can accept that. If you're taking off skin cancer, mark it anatomically. So you need to have a marker stitch, and that needs to identify which bit is proximal, which bit is distal, which bit is superior, which bit is inferior. If it's limb, proximal. If it's any other body part, superior. But always put the marker stitch in the same place every single time, because if there's a day that you don't document for yourself, where you put the marker stitch, you know you always put it 12 o'clock proximal or 12 o'clock superior. If you change it every single time, then it gets difficult. If you're going to put two stitches, put the long one lateral and the short one, and the short one superior, just to make it easier to remember for yourself. And then an approach to closure for a wound this big, if there was enough laxity to close it, you put in some deep dermals starting in the apex, bring it in, maybe put that temporary stitch in the middle to take off the tension, and then run a subcuticular after. If you're going to do a skin graft, it's just the grafting that area in the middle. If you're going to purse string it, again, you don't need an ellipse to purse string. Just take it off as it is and do that. Do you have any questions that I can answer? And then when you're just yeah. Yeah, that's a good one. So let's see what I can do, what I can pull out from my drawer of cupboard tricks. Tips on suturing the face. Here's a face I already had. And so some key tips to note. Let's start with the ears that I don't have on here. You don't need to stitch cartilage, but you do need to do a good debridement. Use dissolvable stitches if you're burying anything inside deep dermal just to anchor things. Use sutures that are high contrast to drive blood and to hair. So often Proline is good because you can see those stitches. And the reason why I'm suggesting using non-dissolvable sutures is because keloids are a risk on ears, shoulders, and sternums. Prolonged inflammation causes keloids. Trauma, you can expect that. Infection, you can expect it. So non-dissolvable stitches that you can remove and not have any dissolvable stitches in is often a good idea. Before you do anything on the face, my first tip would be mark it. So let's say you've got the lip. Always mark the vermilion border where before you put any local in, the normal, so let's say the cut is here and the lip is hanging here and here and everywhere. Mark the border where the mucosa meets the normal skin. And the first stitch you put in after you put the local in is the stitch that aligns that vermilion border. You can, in terms of lips and forehead and nose, you can do blocks. We've got some videos on the website on blocks for the face, but for the lip, the alar, and some of the columella, you can do an infraorbital nerve block to get the patient to gaze forward, find the mid-papillary line, and there's a notch, you can feel it on yourself. For a little divot in your zygoma, that will be the infraorbital foramen. You can either put the injection straight down through here, not straight into the foramen, somewhere down in the same line as it, and aspirate and then inject. That will numb half of the nose laterally and the upper lip on this half, and same thing on that side. The thing that you will need to notice is that if you go through the skin and do it that way, you are more likely to also numb the branches of the facial nerve. So don't be surprised if the patient's face suddenly starts drooping on one side. But warn them about that, but also be ready for it. So then you put your first suture into here. The other way is to go in through the mucosa. So you lift up the lip in front of the tip, go into the mucosal surface of the lip, go straight up and inject. It's probably less painful as well. Just make sure you've got good vision so you don't go into the gingiva and you go actually into the mucosal space and inject. Less painful, same effect. So always mark that bit first. When you stitch the lip, always use a dissolvable suture like Vicryl Rapide, fast dissolving. Stitch the muscle, orbicularis oris, separate to the actual lip itself. With the muscle, you can use Vicryl, normal Vicryl. But the lip itself, use something dissolvable like Vicryl Rapide or any of the other substitutes by other brands. For the face, if you've got a lip cut that extends continually up, You can use dissolvable or non-dissolvable. The choice is yours. Lots of reasons to use one or the other. That's up to you. Same thing for eyebrows. Mark the eyebrow, mark the eyebrow. But on the face, there's this tendency, especially in children, to use glue because obviously you don't need to put them asleep for that, and it's easier. The one thing you need to remember with facial wounds, or any wound really, is the question of whether you need to stitch it or you can just put stereo on it, is one, can you, in your skill set, get better approximation of the skin edges? The closer the skin edges, the narrower the scar. If you can get better approximation, stitch it. There are things you can do to stitch in children that you can do under local to make it a bit easier for you, and I'll talk you through my techniques. The second thing you need to remember is the face has animation, right? So you've got frontalis pulling the eyebrows up, orbicularis pulling the eyebrows down, nasalis pulling the nose up that way, corrugator and procerus pulling the forehead that way. You've got the zygomaticus major minor risorius pulling the face that way. You've got the depressors of the lip. You've got the levators of the lip. Everything is pulling in different directions. So when the patient is unhappy and sad and sitting in front of you with no facial expression, that wound may be closed. But the second they start smiling or eating and drinking, if that pulls the wound apart, you're going to have a worse scar and it's going to take longer to heal. So that would be an indication to stitch it. And in that instance, even if it's just looking like it just needs a couple of superficial stitches, you may want to put a deep dermal in just to approximate it well and keep it healed, and then something superficial that will come out in 5 to 7 days. That's for the face. In terms of how I stitched kids under local, well, if they're old enough, first thing is you get that lac gel and you put it in the wound, or Emla cream, put it on the wound. Then you get Entonox, the gas in the air, let them have that for a couple of breaths, and then you put the local in. Get parents to distract them with games. The Entonox makes them laugh and happy. That allows you to put the local in. By the time that's all over, then you can stitch in peace. And that avoids the GAs and that kind of things. If you can get a better scar and you can bring the edges together better, stitch it. If that means you have to do it under GA, then so be it. But you have to just remember that the distracting forces of the face are likely to pull the wounds apart. When it comes to stitching web spaces, I'm afraid I have no tips for you. You just have to struggle. You need an assistant. The thumb is the worst one, I think. No matter where you sit, there's always going to be a difficulty. I think having flexibility in how you hold your instrument is helpful. Put in the key spots first. So if you've got a cut going like this, like this, like this, put the one that anchors this to this, this to this, and this to this, and then just put stitches in halfway after that. And if you have any more gaps, then you put more in. With regard to the other structures like the nose and the eyelid, the nose is fairly straightforward. The face bleeds a lot, so use adrenaline in your local anesthetic. We have pre-made local in the UK, Lignospam 1 in 80,000, I think, usually, or xylocaine. You don't get tip necrosis with that concentration, but obviously if the patient has lots of comorbidities and is a vascular path and the tip is already blue, or pale, don't use xylocaine. Um, but just anchor things. The first suture should be the thing that aligns everything else first. So anchor the one that puts everything into the middle, anchor the alar back, that kind of thing. With the eyelid, now that's an important one. That's a tricky one. Very, very thin skin, very, very specialist. If it's not full thickness, consider a really fine suture, 5060. Consider a pull-out suture, like a Prolene, subcuticular, go in on one side and come out on the other, and then that can be pulled out in a week's time. But if it's trauma, you may just want to do simple interrupted sutures. On the face, in terms of dressings, chloramphenicol ointment or any paraffin-based ointment, it's often easy because you can't get much else to stick on the face other than some simple tape. Chloramphenicol ointment is a bit more discreet than big white plasters all over the face. The scalp, people say staples. Personally, if you're the person that has to remove those staples, it's not that nice to take them out. Easy to go in, not that nice to take out. So often I will use a big suture, a 3O something, but make sure it's high contrasting like a Prolene and leave the suture long so the poor person has to take it out, can find it, or use dissolvable stitches. So those would be my tips for extremities and faces and in pediatric special circumstances. Um, yeah, so before you operate on any wound, if it's trauma, clean it. So my technique for cleaning, if the patient can't be showered, so either shower, lots of wash, and then if they've got lots of gravel, I open up the gauze, I soak the gauze in saline, open up the gauze, get my forceps, I wrap it in the forceps like this. Once I put my local in, or if they're asleep, and then I scrub it. If you're in a theater and they've got tattooing from the gravel, the other thing you can get is a sterile toothbrush or a scrub sponge. A toothbrush is quite good. A toothbrush is quite good, and you can focally scrub the area. But failing that, forceps and scrub it, or you get a ruler, metal ruler in the scrub tray, and brush it off. And if it has pinpoint bleeding, it's good, but it's important you get any macroscopic debris out and you brush the edges. The bleeding just tells you that the skin is alive and viable and doesn't need to be excised. I'm quite generous with my excision on body parts, except on the face. On the face, I'm more of someone that would just maybe get the scissors and trim the edge and then just give everything else a really, really, really good scrub because you haven't got skin to spare on the face. The key to the bleeding is not just to make it bleed. You just want to make sure that it is viable. If it's not viable, you have to cut the skin back. And the key with trauma is that not everything has to be closed there and then. If you can't close the wound because it was all unhealthy, refer it to plastic surgery. So debride it, take pictures, temporize it, and get plastic surgery to come and clean it. If you've got a plastic surgery, then the key is that you don't have to do everything in the first sitting. Debride it, debride it, debride it till it's healthy, it's bleeding, and then you do the reconstruction as a later procedure, whether that's skin graft, closure, whatever. If it's not going to close, put a vac negative pressure dressing on it. If it's going to close, then you can maybe temporize it and just put a simple stitch into it just to keep it a bit closed so it doesn't stay gaped. But if it's dirty, put a vac on it. Uh, don't be forced to do everything in the first surgery when it comes to trauma. Any other questions? I quite enjoyed the session. I thought it was quite informative. Um, if, as I said, the replay will be sent to you pretty much within the next hour for today's session, and all the sessions for the week will be on there as well. And we've got more sessions tomorrow and Friday, and then tendon repairs, I think, is on Saturday. So a busy week ahead. If you haven't got any more questions, I wish you good evening and good night. Take care. Bye-bye. Take care. Sleep well.